Matt, as you know, was also a founding member of this society and the first secretary of BSET, and has got extensive experience with the endovascular management and open management of ruptured aneurysms. So, Matt, I'd like to ask you to come up and share that with us.
Thanks, John. So it is truly a great privilege and honour for me to give this lecture. Chee was a friend of mine. He was born in 1961, so he's my generation, and I think it's true to say that he was one of the outstanding vascular surgeons of our particular generation. He worked in Belfast City Hospital and was professor at the University of Ulster, and you see him here with his wife and kids. As John said, he was a founder member of BSET, and this is the earliest photo that we have, we think, of a collection of people who founded BSET, and there's a few things to note. Chee's actually taking the picture. What do we think of Mike's trousers? And it's good to see that, true to form, the Secretary of the Vascular Society is, as usual, cuddling the Secretary of BSET at the moment, just on the right-hand end. One of Chee's achievements actually was to sort of foresee the endovascular revolution, and actually I think it's fair to say he was instrumental in introducing endovascular repair for ruptured aneurysms as pretty much a first-line treatment in Belfast City Hospital. And you see him here, as usual, hiding in the background while Bernard pushes himself forward like a god of the unit. And you can see actually Bernard's here, Raggy Makar, Steve Badger, who are all at the meeting today. And you'll also notice Willie Lone on the right of the picture, who helped drive this practice. So, as John said, one of Chee's big research and clinical interests actually was endovascular management of ruptured aneurysms, and I thought it appropriate just to give the lecture on that subject today. So, as we were talking at breakfast this morning, this must be the most well-used slide in the history of vascular surgery. So this is pretty much the only slide any of us can find on open repair of ruptured aneurysm. It's from Peter Bell's, and actually Ian Loftus used it in his inaugural lecture 2 weeks ago. So, ruptured aneurysm. So what I thought I'd talk about is a little update on the current state of play. I wanted to touch on non-intervention rates in the UK, on organisation of vascular services and service reconfiguration, and then touch on the role of endovascular therapy. So where are we? Well, this is the classic slide, I think, that stimulated reorganisation of services and reorganisation of aortic surgery in the UK. This is the VascuNet report 2008 that famously showed that the UK really wasn't very good at doing either elective infrarenal aneurysm surgery or ruptured infrarenal aneurysm surgery. We comfortably led the mortality rates in Europe. And although you can argue and you can quibble about the validity of those data, they stimulated a change in practice. And actually, if you think as what's happened in aneurysm surgery across the UK in the last 5 or 10 years, the focus has been pretty much on elective repair of infrarenal aneurysm. So we've gone through varying iterations of reconfiguration of vascular services. We've had a definitive aneurysm quality improvement programme, the initiation and rollout of the national aneurysm screening programme, and we've also seen, in allied to those service reconfigurations, rapid uptake of endovascular repair and public dissemination of results. And taken as a body of work, that's influenced our mortality results. So this is the report from the Vascular Society in March 2012 that looks pretty much at UK practice between 2008 and 2010, and we've seen a shift in mortality which has dropped from 7% to 2.4%, and we've also seen an increase in the number of patients treated with endovascular aneurysm repair. 57% of these patients now get an endovascular aneurysm repair with a mortality of just under 1% as compared to 4.3% in open surgery. And that's had an impact, actually. So this is the paper that Janet Powell was senior author on, looking at the decrease in mortality from abdominal aortic aneurysm rupture. So that increase in elective surgery coupled with decreased smoking rates and possibly an improvement in ruptured aneurysm surgery has actually led to a decrease in the number of deaths per 100,000 of the population who are dying from ruptured abdominal aortic aneurysm. But this death rate decrease has been driven by an increase in elective surgery and a decrease in smoking rather than any improvements in the treatment of ruptured aneurysms per se. Because actually, if you look starkly at what happens to patients when they have a ruptured aneurysm, it's a pretty miserable story. So this is a paper from the Netherlands looking longitudinally at population between 1977 and 2012, and if you look at patients who have a ruptured aneurysm, about a third of them die before they get to hospital. Of those who do get to hospital, another 40% get no surgery, and of those that are finally left to undergo repair, their perioperative mortality rate is just over 50%, and there doesn't seem to have been much of a move in that particular mortality rate over those decades. So if you think about the current landscape for ruptured aneurysms, actually we're doing pretty well electively because deaths from ruptured aneurysms are decreasing, driven by public health trends and increased elective surgery. There's a variation in outcome, we know, both nationally and internationally, and actually if you look over time, there's really no discernible progress in the mortality of patients who pitch up to hospital with a ruptured aneurysm. And therefore, as we're looking at mortality rates of around 50%, there's potentially very large gains for quality improvement. So I want to talk about three particular aspects. I want to talk about non-corrective treatment, service organisation, and then the place of endovascular surgery in ruptured aneurysms. So we're absolutely obsessed when we talk about ruptured aneurysm treatment on perioperative mortality rates. We know that these run at about 40%, and the scope for improvement is probably relatively limited. Alan Carthy actually presented yesterday some data that I'm going to show you, but I think it's worth repeating because there's very little attention directed towards the incidence of non-corrective treatment for ruptured aneurysms. So those patients who we admit to hospital, we don't intervene on them and they die because non-corrective treatment is inevitably fatal. If we can increase our operative rate on these patients, there is potential for great improvement. So, this is Albert Einstein. He died of a ruptured aneurysm a few years after Nissen operated on his intact aneurysm and wrapped it with cellophane. And that just shows you shouldn't let general surgeons operate on blood vessels. So it's appropriate in some patients to offer them non-corrective treatment. When Albert Einstein was admitted with his ruptured aneurysm, he said, "I want to go when I want. It's tasteless to prolong life artificially. I've done my share. It's time to go, and I will do it elegantly." And they're often reported as his last words. But that shouldn't be the norm, I don't think. And in the UK, we've got a problem with the number of patients that we operate on with ruptured aneurysms who present to our hospitals. So this is some work that Peter Holt did and reported in the British Journal of Surgery in 2010. And essentially what this graph shows you is to look at the blue columns. These are the percentage of patients admitted to UK hospitals who didn't undergo any form of corrective surgery for their ruptured aneurysm. And the Q1 to Q5 are hospitals split up according to their annual workload. So the Q1 hospitals are the smaller, low-volume hospitals. Q5 are the big teaching hospitals. And essentially, if you go to a small hospital with your ruptured aneurysm, less than 50% of patients are going to get an operation. And I think that's probably inappropriate. Alan showed you these data yesterday, which again is an updated version of palliation rates between 2005-2010, comparing English data from the hospital episode statistics to USA data. and I know he showed you this data yesterday, but I'm going to show it again. If you take these patients between England and the USA and you compare them with regard to what happens when you're admitted to hospital with a ruptured aneurysm, it's actually a pretty miserable story. If you look at absolute rates of mortality between open surgery, between patients who've got endovascular repair, there's not too much difference between the USA and the UK. But if you look at in-hospital mortality, it's 65% versus 53%, and that is entirely driven by our failure to operate on patients who pitch up with ruptured abdominal aortic aneurysms. Just less than 60% of patients get an operation in England as compared to just over 80% in the UK. So non-corrective treatment of ruptured aneurysms, I think, is something we should work on. I think I've shown you that there's substantial variability in practice, both within the United Kingdom, according to what sort of hospital you work in, and also across continents. And I think the conclusion is relatively simple. We need to operate on more patients with ruptured aneurysms. We need to undergo a paradigm shift where intervention should be the default option and not something that surgeons needed to be persuaded to do. And we quite simply need to change our outcome measures. We need to stop talking about perioperative mortality rates, and we need to start talking about in-hospital mortality rates. But you know, in the current climate, that's difficult, isn't it? Because this man, Jeremy Hunt, or potentially a landmark problem, that. So Jeremy Hunt likes publishing individual surgical data, and there is a media and government agenda to beat up on individual doctors to try and cover up the faults in the system. And whilst we have to do this, we are in danger of a risk-averse culture developing where we're not going to operate on sick patients because they're going to adversely impact on our outcomes. And I think we have a real problem to address here. So moving on then to service delivery, a lot of you will know I was keen on service reconfiguration for vascular surgery, largely driven through volume outcome data, and ruptured aneurysms are no different to elective aneurysms. There is a reasonably robust relationship between an individual hospital caseload and your mortality if you pitch up with a ruptured abdominal aneurysm. And if anyone has any doubt, you just need to remember that graph that I showed you of palliation rates, where there's a 30% difference in intervention according to what size of hospital you're in. And Alan showed you these again yesterday. So these are data of how our service is organised in the United Kingdom. If you pitch up with a ruptured aneurysm in England, just under 30% of patients will be treated in a teaching hospital, as compared to just over 50% in the United States. And if you look at every single outcome parameter, mortality, non-corrective treatment, the proportion of patients undergoing endovascular repair, and in-hospital mortality, you will see that patients do better in a teaching hospital than a non-teaching hospital. Similarly, if you look at the same parameters split up by the size of the hospital, so low, middle and high bed capacity, again, your outcomes are significantly better if you are in a bigger hospital. And we don't do this well in the United Kingdom. One of the issues is why, of course, with volume outcome relationships. So why do you do better if you're in a bigger hospital? And we really need to unpick this if we're going to change our service configuration. So one of the issues is what I alluded to with the old Albert Einstein. If you're operated on by a general surgeon, you've got a 50% chance of dying. If you're operated on by a vascular surgeon, your mortality rate perioperative drops by 20%, and you probably have a higher chance of getting an intervention. Historically, if you're in a bigger hospital, you're likely to have more surgical specialisation, you're likely to have more pure vascular surgeons. But that's clearly not the entire story. One of the issues we need to look at when we think about how we organise our service is how we look after our patients following surgery. This is a paper that is on aneurysms. It's not entirely on ruptured aneurysms, but it makes the point. if you do an analysis and you split up hospitals according to whether they have a high mortality for aneurysm surgery, a middling mortality or a low mortality, you will find that the incidence of severe complications in all three of those hospital categories is broadly similar. What is different and what drives their differential mortality rates is the ability of these hospitals to rescue patients after they've had a complication. So if you're in a hospital that has the ability to respond quickly to a patient having a post-operative complication, you will get low mortality rates. And this is seen in this definitive study that was recently published in JAMA Surgery. That's a bad sign.
Should we wait for a second?
I guess.
Mr. Bicknell will sort it out, hopefully.
We either wait for a second or run outside.
It's all right. Fire exit's there.
And it's raining. Okay, so I'm on failure to rescue, and this is pretty much a definitive study on it. So the last slide that I showed you, I'll just go back, is hospitals split up according to their mortality rates. We're talking about volume outcomes, so this slide shows you mortality, complications and failure to rescue rates according to the bed state of your hospital. And essentially, if you look at low volume hospitals versus high volume hospitals, again, complication rates are broadly similar. The mortality rates in the high volume hospitals are much lower, and that is pretty much driven by a much higher ability of these high volume hospitals to respond to complications and rescue patients when they've had a post-operative problem. So failure to rescue and the size of your hospital clearly plays into your mortality rates following ruptured aneurysm surgery. Well, again, why? So this is a difficult study to explain. It's from Barros, who sat down there, who kindly made it available to me. It's not published yet. What you're seeing on this table are odds ratios of dying following presentation to a hospital in England with a ruptured abdominal aortic aneurysm. And you are looking at structure and process. So, for example, we're looking at consultant staffing ratios per 100 beds in hospitals that have been divided into the lowest tertile, the middle tertile, and the highest tertile, with the highest tertile being the hospitals with the best staffing ratios. And they have an odds ratio of 1. So if you look at consultant staffing, the odds ratio, if you've got a poor consultant staffing ratio, is nearly double that as if you're in the highest tertile. So we double our mortality rates if we don't staff our hospitals properly. And this comes back to my point about Jeremy Hunt. He's making us report individual consultant mortality ratios where actually we're in a system whereby we've got inequality over the numbers of staff in our hospitals and the number of critical care beds. And again, if you're working in a unit and you're worried about your mortality rates, then yeah, sure, you look at your individual practice, but you need to look at the structure and processes in your hospital as well. And talking of structure and process, my last little bit of this lecture is about ruptured aneurysms and the place of endovascular surgery in the treatment of that condition. And I go back to Chee, who actually did a lot of the early work on ruptured aneurysms, talking about endovascular surgery being potentially physiologically better for patients, giving them less of a surgical insult, talking about the ability of endovascular repair to get an aortic seal very quickly, putting balloons up both within the device and out with the device to get rapid hemostasis, and also describing the different spectrum of complications that we see following endovascular repair and the need to measure and monitor compartment pressures. So where are we with endovascular repair of ruptured abdominal aortic aneurysms? And it's a difficult one, isn't it? Because there are certainly going to be some patients, such as this patient who's one of Ian's, with terrible polycystic disease, who trying to repair this ruptured aneurysm open is going to be a nightmare. And on an individual basis, they do very well with an endovascular repair. But when we're actually trying to define the place of endovascular surgery in the management of ruptured abdominal aortic aneurysms, the evidence has been difficult to come by. Most single-centre series certainly show an improvement if you treat patients with an endovascular arm. However, we know that both the French and the Dutch trial, who took patients morphologically suitable for both endovascular and open repair, with ruptured aneurysms showed equivalence. And actually, the best sort of our data comes from the improved trial. We were lucky enough to hear the morphology results yesterday, where randomisation was done at clinical diagnosis. So, what did the improved trial show us? Well, it showed us a number of things, actually, and some concerning things right at the start. So these patients were randomised at the point of clinical diagnosis, and again, as is typical in the United Kingdom, 350 of those patients were immediately excluded because it was thought futile to operate on them. 111 of those patients were excluded from the trial because there was no endovascular option available for them in these large hospitals that randomised in the trial. So we cannot provide a 24/7 endovascular service. What about the results of the trial? Well, Janet showed you this slide yesterday. We saw that if patients actually got an endovascular repair in either arm, their mortality rate was around 25% as compared to 37-38% in open surgery. But we'll come on to the morphology later. That appears to be morphology driven. We also saw that if you did a differential analysis, it appeared that some patients did better with endovascular, so women and possibly those that were physiologically more sick, those with a Hardman index greater or equal to 2. We also saw potentially that you might improve your results of endovascular repair by doing them under local anaesthesia. There's a very stark 20% difference in absolute mortality here. So these all give us hints about how we might drive our practice in the future. And we also may see patient benefit in that the patients in this group, out to 90 days, if you got an endovascular repair, you are much more likely to go home as opposed to those patients who got open repair. And clearly, we need to wait for the 1-year data to see whether that trend is going to be continued. So this is a personal view. Does endovascular repair have a role to play in ruptured aneurysms? Well, I think it will inevitably have a significant role. And I think actually, if you're going to set yourself up as an arterial centre, you should probably be able to offer both open and endovascular options to patients who present with ruptured aneurysms. However, we're at the stage at the moment where, looking at the data Alan presented yesterday, we've got a ruptured aneurysm endovascular treatment rate of 10%, and this is probably too low. What we do need to do, however, is define the cohort that will benefit most. And actually, there's some interesting findings in the data that Rob Hinchliffe and Janet Power presented to you yesterday, looking at the mortality of patients undergoing either endovascular or open repair with regard to how long their neck is. And you can see where we need to make the improvements. We need to make the improvements in the patients who've got short necks. So you can see there are not that many patients in this particular analysis, but 50% of patients with a neck length less than 14 millimetres are dying. And that suggests we're probably not very good at treating juxtarenal aneurysms or aneurysms with short necks. So how are we going to evolve this with regard to endovascular repair? Well, we either need to say we need to be better at open surgery, or we need to say we need to evolve our endovascular practice so that we can treat short neck aneurysms. And this is going to come in the next few years. We will get off-the-shelf fenestrated grafts. We showed you yesterday some pictures of chimney grafts and parallel grafts with polymer-based technology. And this, I think, is going to come, as I think it will come with specific bifurcated grafts that are going to be designed with dedicated stents for chimney technology. However, it looks as if there's always going to be a need for open surgery. And I think we've got to understand and comprehend whether every vascular centre in the United Kingdom at all times is going to be able to offer open surgery for short-necked aneurysms to a high standard. And that may not be the case. What about endovascular? Well, here you go. Here's an optimistic assessment from Mario Lachat's group. complete replacement at open repair for ruptured aneurysms by endovascular aneurysm repair. And they postulate here, perhaps optimistically, that you can treat 100% of patients with any rupture anywhere in the aorta by endovascular technology. Good luck. So, this is my last slide. What happens in the future? I think we do need to have a debate about the organisation of services and get patients to the correct place. And actually, it may well be that we're going to have to identify very high volume teaching institutions that are good at repairing patients with short-necked ruptured aneurysms, because that's where the improvement is going to come. This relies on early diagnosis and appropriate treatment. But I think the message that we should all take out is that intervention should be our default option, and we need to stop non-corrective treatment in a large proportion of patients. Thank you for listening.